All right, let's go ahead and get started. Good morning, everybody. I hope you all can hear me. Welcome to the third installment of the SEOW webinar series. Today we're going to be focusing on the contributing factors and intervening variables of substance use in Maine. The first webinar we focused on a few days ago was on the substance use and the prevalence rates of substance use in Maine. And then yesterday we focused more on the consequences, the impact, the repercussions of substance use in Maine. And today, here we are with contributing factors. As for a little housekeeping, I did just put you guys on mute, just to limit background noise. I do ask that we kind of wait for the end of the presentation to take questions, but if you do happen to have a pressing question, go ahead and type it into the chat box on the bottom right hand of your screen. So basically, I just want to explain what these webinars are all about. We put out these SEOW reports, which stand for State Epidemiological Outcomes Work Group, and we put out annual reports on a state level as well as public health district levels. And they're fairly lengthy, and so we just use these webinars as another resource to digest that information for you, because we know it can be sometimes challenging to comb through those reports and find the salient findings, or the key findings, I should say. For today's agenda, if you've joined us in the past, it's very similar to the other webinars. First of all, I just want to give a brief introduction and give you some of the major objectives of the SEOW. Then we'll go over the actual presentation, the data of the contributing factors. And before we take questions, I did want to kind of steer you guys towards some new and updated resources that the SEOW has recently produced. So let's go ahead and get started here. So the purpose of the SEOW, here are the major objectives. First of all, we're here to promote systematic, data-driven decision-making. Second of all, we're here to help really the prevention professionals in Maine, some of the stakeholders and the public health coalitions around the state who are focusing on substance use prevention strategies. We're here to really help them guide effective and efficient uses of their scarce prevention resources. And we're also obviously to identify and track substance use trends over a period of time. And the fourth objective there is to detect some of the emerging trends, the emerging substances or the emerging behaviors that haven't always been on the radar but are definitely gaining some momentum. And lastly, and I think it's a very important objective of the SEOW, we're here to serve as a clearinghouse of a ton of information out there, and we're here to help facilitate a data-driven conversation. So when we're talking about contributing factors, we're talking about intervening variables. So we're talking about attitudes and perceptions and different elements out there that can contribute to substance use. So here are some examples on the screen there: social access, retail availability, pricing and promotion. Some of the community norms and acceptance of drug use definitely can affect whether or not somebody in the community is using. Enforcement, perception of enforcement, and perceptions of harm is a big one, and perceptions of the risk caught. So these aren't, these are just examples. They don't end at just these examples here. And I really think the contributing factor data is really important for all the prevention professionals to really keep their finger on the pulse there of these, because it's these intervening variables that you guys all have the potential to affect. And it's through education, information dissemination, and interventions and prevention strategies. It's really these indicators and these types of contributing factors that you have the potential to affect. So I'm just going to start off here with perception of harm from binge drinking. So on the left-hand side of the screen, we can see that it's the high school students perceiving harm from binge drinking weekly. So the question is, do you think it's risky or it's going to harm your health if you binge drink once or twice a week? And again, just to remind you, some of you that might not be familiar with the data, but binge drinking means 5 or more drinks in one sitting if you're male, and or more drinks in one sitting if you're female. So as for the high school students, 80% in 2015, so 81% felt that binge drinking once or twice a week was harmful to their health. And we have seen an increase since 2009. So we've seen an 8 percentage point increase from 2009 to 2017. So I really think it's a good indicator, and it's good evidence that some of the messaging and the prevention work is getting through. On the other side of the spectrum here, on the right side, we have the adults perceiving great risk from binge drinking on a weekly basis. Here we can see that the 18 to 25-year-olds are the least likely to perceive harm from binge drinking on a weekly basis, with about 27% of them reporting a perception of harm. And that's depicted in the pink line on the bottom. And then the 26 and older population, they have a slightly higher perception of harms at 36%. So really, again, that 18 to 25-year-old population, that's where we really need to target some of these strategies. So just like the substance use and prevalence rates, 18 to 25-year-olds are that age group that are most likely to engage in risky behaviors, and they're least likely to think they're going to be harmed by these risky behaviors. Moving on to perception of harm from marijuana. On the left-hand side of the screen, that's high school students perceiving risk from smoking marijuana once or twice a week. This question was reworded in 2013. That's why I only have 2 years of data here. I believe it used to be perception of harm from smoking marijuana on a regular basis, and that's kind of open to interpretation. So here they defined it as once or twice a week. And so in 2015, we're looking at 4 out of 10, or 2/5 of students felt that smoking marijuana once or twice a week would be harmful to their health. So conversely, we can say that about 6 out of 10, so quite a few students, over half, felt that smoking marijuana wasn't that risky. If we shift to the right side of the screen, we're looking at adults perceiving risk from smoking marijuana at least once a month. So it's a different indicator. It's a different source. We have to remind ourselves that this is a different methodology of collecting data, but the question's different than the high school question. This one is asking if you think it's risky for smoking at least once a month. Again, we can see that 18 to 25-year-olds are the least likely population to feel that they're going to be harmed. And in 2013 and 2014, only 8% of 18 to 25-year-olds felt smoking once a month would be harmful to their health. And that's decreased over time. Since 2019, 2009 and 10 period, it was 13%. So it's decreased by 5 percentage points since that time period. And then the 26 and older population, about a fifth of that population, 21%, felt smoking once a month would be harmful. And that's decreased as well. So just quickly, this is taking that perception of harm from smoking marijuana indicator and looking at it on a public health district level, there isn't a ton of variation across sub-state levels, but I did just want to kind of show you on a sub-state level that all regions are struggling with this, and there were slight decreases in just about every region. And again, this is the perception of harm from smoking marijuana once a month, just among the 18 to 25-year-olds, and this is trending over several years of data here. And we can see there's been pretty notable decreases across the board here. And on a national scale, if we step back and look at the entire U.S. here, this is looking at perception of harm from smoking marijuana once a month. So this is a NISDA indicator. This is National Survey of Drug Use and Health. They put together a map here for the years 2012 through 2014, so they combine those 3 years. This is looking at 12 or older residents and their perception of harm. So red means a lower perception of harm. Dark red means the lowest. And so we can definitely see that Maine sub-state regions have some of the lowest perceptions of harm in the country. In the Northeast has a very low perception of harm comparatively to the rest of the country, as well as some of the northwest parts of the country. This looks at high school students who reported they'd be seen as cool if they drank alcohol or smoked marijuana. So in 2015, about 1 in 7 high school students thought they'd be seen as cool if they drank alcohol or smoked marijuana. And rates have remained relatively stable over the past several years, hovering around 15, 16, 17% there. This is from the parent survey. SAMS puts out a parent survey every other year, and kind of to help kind of compare the trends from the Maine Integrated Youth Health Survey to actual parent perceptions and parent behaviors. So here we can see that in 2015, about 2 in 3 parents, so over 2/3 of parents, 67%, felt okay for their teen to use marijuana. And this was a decrease, quite a notable decrease from 2013, from 81% down to 67%. And for the most part, it looks like the fourth option over is the reason why for that decrease. It's, basically 1 in 6 parents felt it would be okay if their teen used marijuana as long as they had a written certificate from a doctor. So 17%, and that jumped from 6% from 2013. Sally, I'm going to go back at the very end. If you could remind me, just because this is being recorded and I just want to kind of get through it first. Thanks. This indicator here looks at high school students who reported their family has clear rules about alcohol and drug use. So there hasn't been a ton of change, but the good news here is that almost 9 out of 10 students felt that their house or their home has clear rules around drugs and alcohol. But you could say, you know, the inverse of that is 12% of students did not feel that they had very clear rules. Here we have the perception of access. So how easy do you feel it would be to obtain drugs and alcohol. And on the left side of the screen is the perception of access among high school students regarding alcohol and marijuana. So we can see that in 2015, over half of students believed that alcohol as well as marijuana was easy to obtain. So 63% felt alcohol was easy to obtain, and 55% felt marijuana was easy to get. The good news here is that these rates are steadily decreasing, so that is good news. And then on the right-hand side of the screen, that's looking at that parent survey that I was talking about. And basically that's looking at parent perception of teen accessibility of prescription drugs at home without permission. So I forget the exact wording, but it's how do you think your child at home could access prescription drugs without your permission is basically the question. And so 35% said yes. So over felt that, yeah, they could probably access it because I don't have it locked up. 59%, so 6 out of 10 said no. 6% said they actually don't have any medication in the house. So I think this is this was a new indicator in 2015, and it's definitely worth tracking over time. Here we have high school students reporting they would be caught by their parents or the police if they drank. So in this, we're assuming that it's without permission here, without permission by the parents. So the good news here is that you know, half of students felt that they'd be caught by parents, and this rate has been going up with time. Not so much with the police. Only about a fifth or less than a fifth of students felt they'd be caught by the police. And I think the question is, if you were to drink in your neighborhood, would you be caught by the police? And that perception of enforcement has stayed pretty stable over the past several years. So here we can see the number of liquor licensees per 10,000 residents. So when we say liquor licensees, this is talking about the off-premise as well as the on-premise sales of alcohol. So your convenience stores as well as your restaurants and your pubs and that kind of stuff. Anywhere you can get alcohol. And we're just comparing public health districts by a rate of 10,000 residents. We can see that Down East has held the highest rate of liquor licensees at 40.8, followed by Mid-Coast at 32.5 and Cumberland at 30.8. The lowest rates were seen or observed in Central at 20.7 and Penquist at 22.8. So this is data from the prescription monitoring program, and it tracks the number of Schedule 2 through 4 prescriptions filled in Maine. So this is data, dispensary data coming from the pharmacies. And 2 through 4 prescriptions is really tracking the most potentially addictive and dangerous prescription drugs. It's not really tracking some of those antibiotic drugs and heart medication, that kind of stuff. It's more after these 3 types here: narcotics, tranquilizers, which include benzodiazepines, and stimulants like Adderall and Ritalin and that kind of stuff for attention deficit. And so this is the sheer number of prescriptions, and we can see that there has been an uptick in the number of narcotic prescriptions prescribed or dispensed from 2013 to 2015. So 2015 there was about 1.3 million prescriptions dispensed. And that uptick, there is a caveat there. Prescription monitoring program started collecting their methodology changed for collecting narcotic information a little bit in 2014. They started collecting or qualifying tramadol as a narcotic, and they also was collecting veteran affairs data, which is great, but if without stating that, it looks like doctors are just prescribing more. So it's important that we remember those caveats. Tranquilizers have remained pretty stable, around 600,000. And stimulants have, we should keep our eye on stimulants, but they've remained relatively stable as well. This is the same data, but just looking at it differently. This is looking at the dispensed quantity of the same prescriptions, but per capita. So when I say dispensed quantity, I'm talking about units. Like it could be a pill, it could be a patch. I used to only say pills, but then I realized you can definitely, there's definitely several ways to administer medication, but we're just talking single units. It's not a perfect way to track the data, but I think it's more perfect than just shared prescriptions. We are working with the PMP on figuring out the best data that we can disseminate. Eventually we'll get to milligrams for milligrams morphine equivalent, that kind of stuff, or day supplies. But basically what this is saying here is that in 2015, depicted by the red dots there, there were 67.6, so about 67 units were prescribed per person in 2015 of narcotics. Tranquilizers were at 26.7, and that was stable, as we mentioned, and stimulants were at 13.8 units prescribed per person, and this is per year, so unit person per year. Here we are looking at similar data. This is just the narcotic data, so dispensed quantity of narcotics per capita, so just like that previous slide, but just narcotics, and then we're drilling down to 2015 data on a public health district level. So not a ton of variation across states, but we can see that there is a higher rate in Central at 87.5. So it's a notable difference between Central and the Maine average. And the lowest rate was observed in Cumberland at 49.3. So Marissa Charette asked, how am I defining units? And units is like one pill or one patch. The data comes from PMP. So if you like a more detailed definition, I'll do my best to look around after the presentation and send you one. So here's some great data from the Northern New England Poison Control Center. And this is looking at substances most frequently requested for medication verification. So these are calls coming into the Poison Control Center, and these are people requesting verification other than law enforcement. So I combined 3 years of data here to get some solid estimates here. And basically what we're seeing is that this, in 2013, 2015, there was a yearly average of about 5,600 calls regarding opioids, and that was followed by 3,300 calls focused just on benzodiazepines and 1,400 calls pertaining to stimulants or street drugs. So again, this kind of matches up with the prescription drug data that we have. And it just really shows that, the potential for diversion out there. Here we have a similar indicator, but this is looking at This is being drilled down to the public health district level. So this is the number of calls for medication verification by drug type as well as public health district. So on the left side of the screen, this is the rate of calls per 10,000 residents. So we can see for opioids, higher rates were observed in Central, and Pinquist, and Western, as well as down east. For benzodiazepines, higher rates were observed in Pinquist, Central and down east. Stimulants, Central and Pinquist as well. And then skeletal muscle relaxants, a ton of variation across the public health districts. So I did want to sneak in a few mental health slides. We can't really define the mental health as or mental health indicators like depression, anxiety as contributing factors. We know there is a strong association between mental health and substance use. The direction or the causation is unclear. But I definitely think it's worth us as prevention professionals keeping a finger on the pulse of these indicators. So I just included about 4 or 5 here. This first one looks at adults experiencing at least one major depressive episode in the past year, and this is by age group. And so a major depressive episode is really defined by the DSM, and it's at least 2 weeks when a person experienced a depressed mood or loss of interest or pleasure in daily activities and had a majority of specified depression symptoms. So it's really a formula that they kind of put together in the NISDA. We can see that 18 to 25-year-olds are the most likely population to have a major depressive episode in the past year. About 1 in 10 in 2013, or a little over 1 in 10, had a major episode in the past year. And then that was followed by 26 and older population at about 8%. So it wasn't a huge difference between the population, but it does tell us that the 18 to 25-year-old population, again, is at risk for some of these. And this indicator is taking some of the briefest data, the behavioral risk factor and surveillance system data. And it's looking at adults who have been told they've had a depression or anxiety disorder by age group. And been told, this means they've been told by a medical profession, not necessarily told by their wife. We're seeing that in the pink lines there, we can see that depression for 18 and older, overall, about 1 in 4 Mainers have been diagnosed by a medical profession for depression. And as for anxiety, about a fifth, 19%. If we look at by age group, we can see that depression was slightly higher among 26 to 35-year-olds and 36 to 49-year-olds. So that age group, 26 to 49, they were the highest age groups to have diagnosed depression. And as far as anxiety is concerned, rates were kind of didn't have a lot of variation between 18 and 49, but we can see that the 50 and older crowd had much lower rates of anxiety. This is a Maine Integrated Youth Health Survey indicator. It's high school students who reported feeling sad or hopeless in the past year. So this is MIAS's way of kind of measuring depression among youth. So it's not necessarily a diagnosis. It's the actual question is, in the past year, have you felt so sad that you stopped doing your usual activity at least 2 weeks? And we can see in 2015, more than 1 in 4, so 26%, more than a quarter, said, yes, I've felt that. And rates, unfortunately, have been increasing in the past several years. But I actually shouldn't say unfortunately necessarily, because maybe there is that possibility that students are just reporting this more, that they feel they feel more in tune with their mental health. And I did want to quickly look at some of the suicide ideation indicators here. These are from the Maine Integrated Youth Health Survey, and this is looking at high school students who considered, planned, or attempted suicide in the past year. So those are 3 different questions. And in 2015, about 1 in 7, so 15% of high school students in Maine had seriously considered suicide, and 13% actually made a plan, and 1 out of 10 actually attempted. So these are definitely indicators that we need to keep our eye on. And the last data slide here, it's not that exciting, but I think it's worth mentioning here. It's the number of 211 referral calls by service type. So in case you're not familiar, 211 is a helpline. It's like it's a directory that directs people towards all kinds of services. And the 3 services types of calls that I'm incorporating here on this chart are housing and shelter, mental health services, and substance abuse services. So we can see that in 2014, mental health related calls actually surpassed those relating to housing and shelter. Both housing and shelter and mental health have seen decreases in the number of calls from 2000 to 2015, while those related to substance use have remained relatively steady over the past several years. But I did just want to show this slide as an indication that there is a demand for mental health services out there. So I'm going to do this quick summary and show you guys some new resources, and then we can open up for questions if there are any. So as I highlighted earlier, most high school students perceive regular use of substances pose a risk of harm. Of course, now that I'm reading that it was excluding marijuana. I don't think it was most students. Most students perceive regular use of alcohol and prescription drugs as harmful. The young adults, probably not very surprising to most of you, 18 to 25-year-olds are the least likely to perceive risks of harm from using alcohol and marijuana regularly. Perception of harm from marijuana has been decreasing pretty steadily among both youth and adults in Maine, and that's reinforcing a more permissive attitude among parents as well as communities. The good news is that more students feel that they'll be caught for drinking by their parents. However, fewer students think they'll be caught by police, and most think that it's pretty easy to obtain alcohol and marijuana. There's still a concern over the availability and ease of access to prescription drugs. That's no surprise there. Specifically, there's a potential for diverting the prescription drugs that remains an issue. There's a lot out there. And over 1/3 of parents felt it would be possible for their teen to actually access prescription drugs at home without their permission. And I think it's really important for us just to keep in mind some of those mental health indicators. We know that there is a strong relationship between mental health and substance use, and I think it's really important for us to understand how to interact with one another and keep those in mind, and so we can really figure out how to best plan the prevention and intervention efforts so we can address the needs of both alcohol or both substance use as well as mental health. So that concludes the presentation. I just want to quickly go over some additional resources that are out there. On the left-hand side of the screen here, we have the state profile that came out this summer. that can be found on the data dashboard within the additional resources section. This fall, we put out the 8 community profiles. Those are on a public health district level. Those can also be found on the data dashboard, which is at maineseow.com. Some fact sheets that we recently produced. On the left here is the contributing factors fact sheet that's highlighted. We also produced a fact sheet for consequences and a fact sheet for consumption. And those can also be found on the website, the maineseow.com website. And this is just a snapshot of the data dashboard. This is what you'll see at the home page. You can go there to kind of drill down on specific data. It's a web interactive query system there. If you haven't checked it out, I encourage you to check it out, and always feel free to give me some feedback. And then there's also a section there for descriptions of data sources and contact information for data sources. And then, as I mentioned, there's an additional resource section. And that's really the clearinghouse part of the data dashboard, and where we store some of our resources, and have links to other statewide resources that could potentially help in planning prevention strategies around substance use. All right, we got a few questions. Jim has a question here. Do you have access to the microdata? You can tie together your 3 presentations in a multivariate analysis linking cause to consequence. Have you done this sort of analysis? No, I'm not there yet, Jim. Yeah, that would take a couple of me, I think. Right now, we really just focus on a pretty basic level, our job is just to have as many pieces of the puzzle as we can put those together. But that's definitely on my to-do list. And in a perfect world, I'd love to do that kind of multivariate analysis. But I'd love to have continue that conversation with you. And Sally is asking, so Tim, was your risk of harm slide for marijuana those who think it's harmful or those who think it's harmful, or who don't think it's harmful? I believe it was for those who don't think it's harmful. And I could have made a mistake, you know. It's potentially I could have made a mistake here, but I think it's those who think it's harmful. Because a lot of the Maine Integrated Youth Health Survey, I actually take the inverse of some of it, because I think their reports report on those who do not harmful. And I just wanted to show you the decrease in the perception of harm rather than the increase, or yeah, the increase. You can get lost in those pretty easily. But thank you for clarifying, or helping us to clarify it. Marissa Charette asked, do you have statistics for perception of harm for tobacco? I would have to say we must have that. There are a ton of tobacco indicators within the Maine Integrated Youth Health Survey, so I'm almost positive we have some of those within the MIAS. I did not present them here, but yeah, if you do want to look for some of those Maine Integrated Youth Health Surveys, I would steer you towards just Googling MIYHS and then Maine, and then you'll get to the Maine MIAS website, and they have all kinds of reports that you can comb through. But I'm pretty sure they might ask that question. And I can help you get that information as well. And we do have links to the MIAS. They have their own data dashboard as well. We have links to that, their website on the dashboard, on the SEOW dashboard within the additional resource section. If any of you on the phone would like to ask a question, I believe you can just press #6 and that'll unmute you. I forgot to mention that. Well, I think I'm going to go ahead and wrap up here. There is my contact information. I really appreciate you guys listening in. It is going to be, this has been recorded, and I'll post it eventually with the approval of the CDC to the SEOW dashboard, and I'll post a PDF of the presentation there as well. Try to get that up within this week or next week, depending on the approval process. And I encourage you all to take a look at some of our resources, and I definitely encourage you to share those resources. And if somebody missed some of these webinars and you think they could potentially learn from these, then please go ahead, feel free to share them.